On Tuesday, June 1st, I had a patient, a 74-year-old female, admitting diagnosis adenocarcinoma of the pancreas, admitted 21 days ago. The patient complained of abdominal pain and then proceeded to go to the ER. She has allergies to iodine and morphine, and she's a do not resuscitate and no escalation of care. Her admitting doctor is Kaligi, and she had consults to occupational therapy, physical therapy, and especially palliative care. Her background is she's not on isolation. Her fall risk was high risk due to no musculoskeletal strength, urinary catheter, and weakness in all of her extremities. She has a Braden score of 14, which was a moderate to high risk. For assessment, the patient was alert and oriented ×3, but not oriented to time. Cardiovascular, she had +2 pulses in her radial, as well as +1 in anterior tibialis and dorsalis pedis. S1 and S2 were heard with a strong regular heart rate. Respiratory was diminished lung sounds in all four lobes, all four no adventitious like sounds. And then she has a history of asthma as well. For GI, she had 2 drains in her stomach. It was the left upper quadrant. She had a biliary drain as well as a abscess drain. During my time, the abscess drain was removed because it was not producing any output. And she had active bowel sounds in all 4 of her quadrants. Her last bowel movement was 6-1. It was brown and mushy and soft. She used a bedpan while sitting up. GU, the patient had a indwelling catheter. Musculoskeletal, she had 1 out of 5 strength in all limbs and extremities, and she had 2 wounds on her coccyx. She did have thin epidermis due to age, as well as bruising due to age. Her psychosocial, she was extremely depressed, withdrawn. The patient kept saying that she was ready to go home. This was no way to live and everything. Her diet, she was on tube feeding via the Dobhoff, but her Dobhoff was clogged. About midway through the shift, we had 4 different nurses try to pressurize syringe normal saline into her Dobhoff, and no one was able to unclog it. This Dobhoff tube was definitely a tipping point for our patient, as she had been on full measures of care, and when she realized that she was going to have to get a new tube placed or unclog the original tube, the patient stated that she didn't want that, and that this was kind of her final tipping point to move towards that comfort care level. Her Accuchecks were 120. She had a pain level of 10. The patient wasn't able to grasp, which made it difficult to measure musculoskeletal. So Dr. Kaligi, while doing his assessment, we used his assessment findings for musculoskeleton because the patient was unable to grasp. She had an IV on her left forearm. And activity, she was a maxicist, but the patient, when I was on care, was not able to leave the bed. Meds that were given while I was there were Lantus 11 units, oxycodone 2.6 milligrams per milliliter, Zofran 20 milligrams, IV Zosyn, and maintenance 9% normal saline. The IV Zosyn was given IV piggyback, as normal saline was the maintenance drug running. She had sodium elevated, BUN normal, glucose was 120, magnesium and calcium were abnormal as well. The patient's blood pressure was 147/90, and she had 94% O2 saturation on 2 liters of oxygen. So the focus of the day was switching that care from interventional to the comfort care. So at around 1 o'clock, the patient's son decided that she was able to go on comfort care measures because the patient's sister had passed earlier that day. And that was kind of, that with the DOP-HOF situation, that was kind of the final tipping point for the patient to receive the comfort care. After we were given the orders that comfort care was now in place, the nurse showed me how the NG tube was taken off, how she was given pain, or lots more oral pain meds than she was given before. She was also given Zofran for the nausea, and no more, finger pricks or insulin given or tube feeding. She could not even tolerate ice chips at this point. And so this was kind of the moment around this 1 o'clock, 2 o'clock time frame where the patient decided that this was enough. So I was able to sit with her and hold her hand, and, just be a presence with her and kind of, comfort her and her son while she was passing. So the patient went very quickly after that. She was still wearing her oxygen, but after that, that was more for her mental sake, but the patient did pass very soon after we were able to leave. Things that the nurse could educate on educating the son on death and dying and why this was important to the patient, and being there for the son. I feel like, the patient had already had it in her mindset that she was ready. The son said things like, "We're going to get you home and get you stronger," while the patient was saying, "I'm ready to go. I'm ready to be done." So I, after spending a lot of this week processing, it was really obvious to me that it's just like what an honor it is to be alongside patients and families going through this, and that it is just such an honor to hold patients' hands when they're going through this. And it definitely solidified the calling on my life that this is where I'm supposed to be, even though I've always said, like, I'm going to be pediatrics or babies or newborn. I was pleasantly surprised that this just brought me peace. Yes, it was emotional, and yes, I cried, but it definitely changed my perspective on nursing in such a radical way that I never want to forget this experience. So yeah, thanks so much, and I'm looking forward to hearing feedback.